So as you mentioned, we are currently running a huge study in children in European population. So I would like to present something coming from our registry, pediatric registry.
We lost you slightly there, Salvatore.
Okay. Okay, can you hear me now?
We can.
Okay, I hope my connection will be good until the end of my talk. I hope so. So sorry for that. I think my connection was fine until a few minutes ago. So I hope this will be in the next 30 minutes. So let me say that as you all know, the EoE has a great variability in terms of clinical presentation. So we can have a very different type of children and adults presenting symptoms of EoE. Since I'm a pediatrician, I usually observe in my clinic many different phases of this particular very unspecific symptoms in younger kids that usually have feeding difficulties or difficulties in failure to thrive and something like that. But in adolescents and older kids, we have symptoms much more similar to the adult EoE. And this is the reason why adult EoE symptoms are very different from children, from pediatric onset, because in children we cannot observe clear symptoms of EoE. We usually observe symptoms that are common to other GIs, such as vomiting, failure to thrive, or even food refusal. So this is important when we want to evaluate a child in a good way, because we should think that that child can have an EoE, even if symptoms are not suggesting EoE. So looking at the definition of this condition, we should keep in mind that this is a chronic condition. So this means that the disease will not go away someday, but probably tends to last for the entire factors. The first factor is clinical presentation. So there is the need. Oh, I think you lost me.
No, we've still got you, Salvatore. We just turned off the video to try and help with the connection.
Can you hear me?
Yes, we can still hear you.
Okay, okay, thank you. Okay, perfect. So the first factor that you should consider is the clinical presentation, the presence of symptoms. As mentioned, clinical symptoms can vary in different ways and based on age, but it's important that you need to consider symptoms, and the ability of your physician is to understand that those symptoms can be related to EoE. This is the most important things that you should keep in mind when you want to assess if your child is affected by EoE. The second factor is the presence of a certain lesion at the endoscopy. So the endoscopy is, the best tool in the hands of the gastroenterology to evaluate directly the presence of inflammation in the GI tract. And you need to evaluate the esophagus in an appropriate way by looking and by looking at the entire esophageal mucosa and by checking for the presence of this typical lesion. But one of the factors that makes a definite diagnosis very difficult is that sometimes you can have also a normal mucosa, and this needs that you should collect samples, biopsy in particular, from the esophageal mucosa, and that biopsies need to be analyzed by a pathologist. And if you have more than 50 eosinophil per high power field, which means that your pathologist is looking at the microscope, and in the certain area, he will find greater than 15 eosinophil per high power field, means that you can have the disease. So there's need to be to diagnose EoE in a child or in adult. Of this condition is a relatively young disease, because the first description was made back in 70, and as you can see, there was different definition. There were different definitions of the disease over the years, until current time, in which we have finally a clear definition according to the latest guidelines. Looking at the incidence, why is so interesting now, and why is increasing over time? This is still unclear, but what is true is that we are going to see a remarkable increase in all the European and Western countries of this condition. As you can see from the beginning of this is described in the literature in any
Just to let you know, Salvatore, we're losing you a little bit. It's skipping in and out. Bear with us, everyone. We're just having a slight technical hitch. I feel like I need interlude music. Please bear with us, everyone. Salvatore is just reconnecting. Need some elevator music. Mary Rose, do you want to drop the screen back to me while he's
You should have screen sharing capabilities, Amanda. Salvatore's screen's gone already.
Okay. Yeah, whilst we're waiting for Salvatore to rejoin, I'd hope that you are all registered to join our next 2 weeks. For those of you who don't know, our following 2 weeks will include Stephen Atwood, who will be speaking next week along with myself. Stephen will be presenting on long-term EoE and the fibrous effects on the esophagus, and also food bolus obstruction. And we're delighted that we will be presenting the new food bolus action plan, which we've been developing over the last few months, and explain to you how we got to the point that we're at, and hopefully be able to share the document with you as well. So that's next week. And on the final week of our Wellbeing March Wednesdays, we're very excited to have Evan Dellen join us, who is our newly appointed international medical advisor, who's written multiple papers, even in the last year, believe it or not, on eosinophilic gastrointestinal diseases. And he will be joining us to present on the global treatments that are current and forthcoming, and will be joining us for a Q&A as well during that week. So we look forward to that. And I believe that Salvatore is back with us. So
yes, sorry, I'm very okay. Sorry.
That's all right. We're having a tour of your house tonight, Salvatore.
Sorry, but it seems that in Italy it's difficult now to connect with the.
It's just connected. We're not going to put it down to Brexit. And you've frozen again. Would it be useful for me to share screen?
Okay. Okay.
Mary Rose, do you think it would help if I shared?
I think it would. Yeah, I think it would help.
Let's get the PowerPoint up.
Probably it would be better to use your.
Doing that screen right now. Bear with us 1 second. Here we go.
Okay, perfect. So we were here, I think. Okay. If you can hear me now. Okay. So basically, what I was saying before, we don't know why the incidence and the prevalence is growing up over the years, in particular in the last years. But what is true that if you look at this map, the majority of countries affected by this disease are northern country and western country. So probably there should be something in the environment that is causing the disease and this higher prevalence. It is also true that in non-industrialized country, there is still the incapacity to diagnose the disease. But of course, it is quite evident that this disease affects Western countries more than non-industrialized country. Please go on. You can move on the next slide. Okay, so what is really important in causing the disease is still unknown. Of course, we need the genetic predisposition, we need the presence of some environmental factor, and we need, of course, the presence of EoE, which is one of the main characteristics of the disease. This condition has been considered as an allergy for a long time. It is a kind of allergy, of course, but it's not exactly an allergy as we considered full, at least IG mediated food allergy, which means that is not a type of allergy that can cause an immediate reaction to food. It causes a reaction to food, but not it is not immediate, is delayed in time. So it's quite a different type of allergy driven by food, of course. Please go on. Move on to the next slide. So if you look at the pathogenesis, as I was mentioning before, there is the presence of some antigens from food, from allergy, triggering the disease and triggering the inflammation. But the real main problem of this condition is what is called defect in the barrier function. So the esophagus is not able to contain food allergen or food allergen, and these antigens comes inside the body, and the immune system determine the disease and determine the disease by recruiting eosinophil that cause the disease and the type of inflammation that we observe at the microscope. The problem of this condition is not the inflammation itself, it's the presence of inflammation for a long time, because this inflammation change over time and become a fibrotic disease. So the most important thing when you manage EoE is to keep as much as possible the esophagus clear from the inflammation, because if the inflammation is untreated, probably this will become a fibrosis, a fibrotic process, and even an esophagus unable to work in a good way. Please move on the next. So just to remind you that this type of disease is caused by some molecular factors that also are present in atopy diseases. And that's the reason because we call this kind of inflammation as an allergic inflammation, because it's determined by eosinophils, which are cells, immunocells, also determining asthma and other type of allergy. But what is triggering the disease are foods and even microbes. So it is important to know that this type of inflammation needs to be stopped at some point, at the beginning by excluding food, or in the middle of the process by using drugs, or by restoring the barrier function of the esophagus by using something that is able to slow down the inflammation. The next. So these slides show you how the disease change over time. So in the majority of cases, at the beginning of the disease, we have an inflammatory process, just inflammation affecting the esophagus. This inflammation, as I said before, change over time and become fibrosis. So this explains the difference between children and adults, because in the majority of children, we have just inflammation. And in many adults, we have more fibrosis than the pediatric age. So it is important to know that when you have children, you more commonly see inflammatory symptoms than adult patients, but it is not a rule for any patient. Any patient has his story. So it is important to understand that even if we, in general, think about children as affected by inflammation and adults affected by fibrosis, we should consider that any patient has his own history, and we should determine this history to understand if we have more inflammation or more fibrosis. Next. Okay, and these diseases, what is very interesting is that it is true that the disease change over time, but it's also true that different phenotypes exist. What does this mean? This means that some patient probably will have more fibrosis regardless their history, regardless the therapy they used. And some other patient will have a more inflammatory disease. So this means that we cannot predict exactly for each patient what will be the outcome at the end of the story. So we need to determine if this disease is related to more to inflammation, to fibrosis, because some patients are tends to have a more fibrotic process than others, regardless the type of therapy. Next slide. So as I mentioned, there is this recent study demonstrating that different phenotypes exist in EoE. And the EoE is we don't have only one type of EoE. We have different type of EoE. Probably each patient has his own EoE. So we need to personalize treatment, understanding if we have more inflammation, if we have more fibrosis, or if we have both at the same time. And this will be the future of this disease, to personalize treatment according to atopy, to the presence of type of gene regulation, to the presence of responsiveness to steroids, to diet, to PPI. So this needs to be understood in a good way before treating a patient. But to date, it is impossible to predict at the beginning of the history what will be the outcome. We can try to understand, we can try to figure out what is the best treatment, but we cannot be sure of that since the beginning. Next slide. So what is very important is that we have a male predominance of the disease. So this means that you will see more commonly male than female having EoE. And this is because estrogens protects against the type of inflammation causing EoE. That's the reason because male are more affected than female. Next. So in terms of clinical presentation, as I mentioned at the beginning of this talk, you will have children with different symptoms compared to adults. And I mentioned what is very common in younger kids is to have failure to thrive, feeding difficulties, nausea, vomiting. These type of symptoms are shared by different GI conditions. This makes the diagnosis very difficult for pediatrician and much more easier for adults. But of course, even adults can have also a clear history or not of the disease. So this is very important to keep in mind that EoE is an intriguing disease and need to be managed by experts as much as possible. Next. So looking at our data, explaining how the disease is different according to the age, as you can see, we can have much more vomiting and growth failure in the European population in children less than 10 years, while in children older than 10 years, you will have much more food impaction and dysphagia, which are characteristic symptoms of EoE. Next. What is another important factor that, as you can see, the majority of endoscopy for EoE diagnosis are performed in case of GERD symptoms, which means that you have symptoms of reflux disease. And this is important to know that sometimes the disease is hidden by the presence of reflux disease. So when you have a child unresponsive to PPI, which are drugs used for reflux disease, are acid blockers. So when you have a child unresponsive to this acid blocker or dependent to these acid blockers, this need to be clarified by doing an endoscopy. And then you have all the other symptoms. And it's also interesting to see that in 5% of cases, you have an incidental findings, which means that these children received an endoscopy for another reason, for example, celiac disease or something like that. And then the endoscopy found the presence of eosinophilic inflammation and made the diagnosis. So sometimes it's very, very unclear the history, and only after the endoscopy is possible to recognize symptoms and to recognize the clinical presentation. So, for example, when you have a child that is drinking a lot during a meal, or he cannot swallow meat or cannot swallow stick, so this need to be considered because it's not the normal life for that age. So even if you have very, very unspecific symptoms, this need to be considered in the diagnostic process. Next. So as I mentioned, what is really useful, the PPI dependency or the PPI resistance, even if you have GERD-like symptoms, for example, heartburn, regurgitation. So if you have just these symptoms, but you are dependent from PPI, this need to be considered. Even if you have presence of other suggesting symptoms or red flags, such as atopy, rhinitis, asthma, or something like that. So all these factors need to be considered in the diagnostic process. Next. So as mentioned, there is a link with allergy, a link in the type of inflammation causing the disease, but sometimes we can also have allergy regardless the presence of the disease. So we have atopy factors, or this individuals with EoE are highly allergic. So you can have rhinitis, asthma, or other food allergies, not specifically related to EoE, but even causing other symptoms or some of the symptoms. So what is really important to assess the disease in an appropriate way by consulting a gastroenterologist, but even by consulting an allergist, because sometimes there are other allergies that need to be treated and need to be identified to have a clear remission of the disease and a clear wellness. So next. So what is really important that you do not perform allergy test because you want to know what are trigger foods. This is impossible by allergy test. You also you should test, you should perform allergy tests just because you want to know if there are other allergies, but you cannot establish a treatment on the presence of a positive allergy test or negative allergy test, because it's impossible to predict trigger food, to identify the trigger food by doing allergy tests. So this needs to be clear in the mind of the physician and in the mind of the patient, because allergy is a part of the story, is not the main story. Okay, next. And for this reason, you have a concomitant food allergy, a concomitant allergy, and this needs to be considered and treated for time, because sometimes we have EoE patients in remission that have symptoms related to seasonality or something like that, so needs to be treated by the allergologist. Next. So, as I mentioned, the atopy runs in the family. So you have, for example, the patient affected by allergy, but even siblings or father or mother. So any clinical history related to atopy could be considered as a red flags for EoE. Next. But of course, what is important to know that there is this deep connection with allergy, but there is also many patients do not having any type of allergy, do not having any atopic disorder. So this is important because sometimes many of my patients ask me why I'm not allergic, why cannot you find any allergy, why I'm not allergic, so why I have EoE. This is because sometimes EoE is extremely linked to allergy, but in other patients you can have any type of allergy and just having EoE. Next. So when we perform an endoscopy, we usually look directly at the mucosa, as we mentioned at the beginning of this talk. These are the specific feature determining EoE at the endoscopy. So we can have inflammatory lesions such as edema, exudates. So these are typical of EoE and are typical of inflammatory EoE. While we have other endoscopic findings, for example, rings or furrow, which are this line in the esophagus, or for example, a reduction of the lumen, which is the stricture. So these findings are extremely linked to fibrotic process and to a fibrotic EoE. So when the endoscopy does an upper GI endoscopy, he can recognize if there is an inflammatory disease or a fibrotic disease. Next. So for symptoms, even for endoscopy, the story can change over time. So in younger kids, probably you will see more exudate or inflammatory findings, while in adults you will find more stricture and fibrotic process. Next. And this was also found in our registry. As you can see, in kids less than 10 years of age, we found more exudate and furrow, while rings were more common in older kids. An important factor to know is that there is a part of EoE patient with a normal endoscopy, which means that you cannot find any type of lesion at esophageal mucosa, but eosinophils are in the biopsies. So this confirms the needing of taking biopsies during the exam. Next. So as you can see, about 20% of patients have a normal endoscopy. So this needs to be considered for physician and for patient, because a normal endoscopy does not exclude the EoE. So if you have a normal endoscopy, this needs to be clarified by examining histological sample. So when you examine histological sample, then you have the possibility to look at the number of eosinophils and to look if eosinophils are there or not. And this helps in the diagnostic process. Next. And what is really important is to take an adequate number of biopsies, because sometimes, for example, in adult unit, you have 1-2 biopsies in the distal esophagus. This is not enough. What is really important is to take biopsies over the entire esophagus, probably 2 from the distal part, 2 in the middle, and 2 in the upper part. And this increase the diagnostic accuracy and increase the chance to make a clear diagnosis. So it's very important to take as much as possible an adequate number of biopsies. Otherwise, the endoscopy is useless, and you need to repeat the exam or need to examine differently the patient to have a clear diagnosis. Next. So, as I mentioned in the beginning of the presentation, there is a certain number, which is 15 eosinophil at microscope, that is the actual cutoff to make the diagnosis. But even if you don't have enough eosinophil, there are other features that need to be considered. So it's very important to take as much as possible an adequate amount of biopsies, as I mentioned, at least 6 at the time of the diagnosis, to make a clear diagnosis, to count to the eosinophils at the microscope, and to have a clear definition of the disease. And the pathologist should be expert in this field, because sometimes if the pathologist is not expert, you cannot have a clear definition of the entire process, the inflammatory process, the fibrotic process. Those features needs to be considered at the same time. Next. So one of the pitfalls in the past in the diagnostic process was the presence of a double endoscopy to make a clear diagnosis, because in the past we thought that there was another and separate condition that was a kind of EoE responsive to this acid blocker, which are PPIs. So for this reason, for many years, we perform an endoscopy as the first step. We treated patient with PPIs for 8 weeks, and then we re-evaluated that patient by doing a second endoscopy. And if at that time the eosinophil count was greater than 15 eosinophil per high power field, then the diagnosis of EoE was made. This was just our classification of the disease. Next. But actually, what is really important in the EoE story, that this classification that we made distinguish between EoE and PPI responsive eosinophilic eosinophilia, which means that you have an inflammation caused by eosinophils, but can be treated by PPIs, was just our classification. Actually, it is the same disease. And the same disease means that it is just EoE responding or not to PPI. It's more simple than we thought. Next. And for this reason, the only difference that we found between EoE and PPI responsive esophageal eosinophilia was just the responsiveness to PPI therapy. So it doesn't matter how do you call this disease, it's the same disease, just responding or not to PPI. Next. Next. Okay, so if we look at the genetic expression, we clarify that point. So we found that EoE and the EoE responsive to PPI are the same disease, even if we look at the gene expression. And this is different than GERD, which is a different disease, and even different than normal subjects. So it's very important to call this disease as a unique disease without any classification according to responsiveness to therapy. Next. So in 2017, there was a new classification of the disease, and this consensus panel clarified that now EoE is the same entity of the PPI esophageal eosinophilia, and EoE can be treated by using PPI as well. Next. So at this moment, we made the diagnosis with the clinical presentation, with the presence of endoscopic finding or not, because we mentioned that it is possible that to have also a normal esophagus. And finally, by finding more than 50 eosinophil per high power field. These three factors are enough to make a clear diagnosis of EoE. Next. So in conclusion, I would like to run through this following point. As I mentioned before, the clinical presentation is extremely variable. So it depends on the age, it depends on the genetic background, it depends on the phenotype, which is different for each specific patient. And the diagnostic process requires an adequate number of biopsies that should be evaluated by an expert pathologist. The PPI therapy is no longer necessary to make the diagnosis. The diagnosis can be made just by doing an endoscopy and taking biopsies with an adequate number of eosinophils. But it is important to know that a normal endoscopy does not exclude EoE. EoE can be excluded after an histological examination, and hopefully there are few stricture in children because many children have an inflammatory disease, but it is important to know that stricture can be found later in life. So it is important to treat the disease in a good way, in an appropriate way, and to diagnose the disease early in life to avoid complication that can happen in adult age. Thank you very much. And next, I would like to present you this survey that we are running in European Center, asking patients actually their experience about EoE and the eosinophilic disorder in general. So it is important, if you have time, to fill out this survey, helping us to understand the disease burden in your life, and even to understand how your physician helped you in participating in the diagnostic process. Because one of the factors able to personalize treatment, which is another important factor we mentioned in the EoE story, is the shared decision making. Which means that if patients participate in the decision making about therapy, about follow-up, about everything with their physician, this helps to have an adequate management of the disease. So it's very important, if you have time, to fill out both questionnaire and to help us to better understand the disease, even from a patient point of view. Thank you very much, and I would like to answer your question at the best of my knowledge.